The first one was Carolina, and so Carolina, just to give you some background, this was the DPP-4 linagliptin versus SU therapy, glimepiride, and it was 6,033 people, and it's got the longest follow-up in terms of a study in the DPP-4 world at 5.9 years median. So maybe we'll start off with David Lau far on the other side. So what were the results of the Carolina looking at DPP-4 versus an SU?
Well, before I talk about the Carolina data, perhaps just to remind the audience that the Carmelina trial was actually done and published earlier, comparing standards of care and people receiving placebo or 5 milligrams of linagliptin. So it was a CV outcome trial. So the Carolina trial is another CV outcome trial, but now we have an active comparator between linagliptin 5 milligrams and glimepiride 1 to 4 milligram up titrated according to the A1C. So after a median follow-up of 5.9 years, the results came out that, in fact, they're comparable in terms of CV safety. In other words, linagliptin is no different from glimepiride 1 to 4 milligrams when it comes to the event-driven MACE or 3-point MACE, namely non-fatal MI, non-fatal stroke, or cardiovascular mortality. However, that said, in terms of the secondary outcome, there was a tremendous difference in terms of hypoglycemia, in particular, moderate to severe hypoglycemia, which was seen mainly in the glimepiride group compared to the linagliptin group.
Okay, all right, so big hypoglycemia, I think the rate was somewhere around
77% reduction.
77% reduction
yeah.
In the people on the side with the SUs, they had high hypoglycemia. Thomas, I mean, you're dealing with SUs all the time in your patients. How does that sort of reflect?
Yeah, so I would say in clinical practice in the UK, SUs are very, very commonly prescribed as a second line after metformin. I should say most patients would be on metformin as first line treatment. And really this is further evidence around potentially the risks around these drugs, and maybe that's something we don't do so well in primary care. You know, we discuss around, you know, particularly if you've got a 10-minute consultation, you're starting medications. It's really about that risk of hypoglycemia and individualizing that to the individual patient you see. We'll be touching later on around the guidelines and having a look at NICE, SIGN, and maybe the Canadian guidelines as well.
Yeah, so hypoglycemia is an important issue, even in a randomized trial where we've sort of told people be careful about hypoglycemia. David, so I mean, Thomas has sort of given us an experience from his center about, you've looked at all sorts of observational data, sort of multiple Thomas's practices. What do you see when you look at
Absolutely, yeah. So this actually was one of the biggest surprises of the whole of the ADA, the fact that this big change in hypoglycemia wasn't associated with cardiovascular outcomes, because we'd seen in multiple previous studies in the observational data of hundreds of thousands of people that sulfonylureas particularly were associated with a much higher risk of hypoglycemia, and that translated to more myocardial infarctions and cardiovascular death. So the fact that the randomized control trial didn't show it is suggesting one of two things. Either these thousands and thousands of patients in real-world trials are not representative of the randomized control study, which is true to a certain degree. In the randomized control study, highly selected populations, you don't get the frail elderly, you don't get the patients who are poorly adherent to the drugs, you get a very select population, or whether there is a lot addition to be said for spending more time with the patients. Remember, when you're in a randomized controlled trial, you're getting regular consultations, 20 to 30 minutes, you're getting phone calls, you're getting all that support to make sure that you are continuing to take your medication. Whereas in the real world, it may well be that a person has a hypo and then they stop taking their drugs, but they're not as well educated as us. So it's not just the sulfonylurea that disappears. It's the antihypertensive, it's the statin, and maybe what we see in the real world data is the personal effect of having a hypoglycemia rather than the actual biochemical effect. The other thing to point out is these cardiovascular outcome trials are looking at cardiovascular outcomes. As our patients get more mature, only about half of our people with diabetes actually die of a cardiovascular event. It doesn't capture the fractured neck of femurs, the falls, the generalized hospitalization, that personal impact. So although I think this does give us good reassurance that with a sulfonylurea in the right person, you are not doing any harm, it doesn't tell us how we work in the real world with those patients that are not included in this very select randomized controlled trial.
Okay, so selected population, very well looked after, monitored very well. And even then, they still had the big hypoglycemia, but at least no cardiovascular difference between the two groups in the randomized trial. Whereas in the real world data, we do see a differential between the two. So maybe for our learning purposes is that if we are using SUs, let's pick those patients, let's warn them about the hypoglycemia, let's try and do some of the things that they did in the trial, but be aware that the hypoglycemia rate will still be high with those people.